afternoon, morning, or evening, everyone. I'm Maggie Westemeyer, and I'm a Director of Clinical Genetic Services for Renasight at Natera. I'm going to present today with Dr. Schneider. So thank you so much. Can you see the screen and hear me well?
Yes, thank you.
Awesome, great. So as I mentioned, I'm just going to move the Zoom pictures away a second so I can, there we go. All right. So as I mentioned, I'm Maggie Westemeyer, and I'm the director of our genetic services at Natera, and a genetic counselor by training. Had the opportunity to work in the clinical setting for a number of years in pediatric genetics, a wonderful sort of jack of all trades kind of job before coming to the laboratory side of things 13 years ago. And I really had the terrific opportunity to help develop our Renasight genetic test. And I've learned quite a bit over these years, these past 5 years now since we launched Renasight, working with clinicians and patients. And so my role at Natera is to direct a team of genetic counselors who specialize in renal genetics and provide clinical support to both patients and clinicians who use our testing. And of course, I'm joined today by my esteemed colleague, Dr. Ronen Schneider, who's our nephrology genetics medical director, who recently joined us at Natera. And we're so glad to have you, Ronen, on our medical team and to speak with all of you today. So thank you. So our objectives today are to give you a brief tutorial and really just a practical review of genetic testing and variant classification, how to understand a genetic test report. And then Ronen will review some case studies to illustrate the use of genetic testing. And then if time allows, we'll accept some questions. So in this first portion, I'll introduce you to some information about genetic variant classification. Just really want to remind everyone that a genetic diagnosis is really a multi-step process that includes laboratory testing where we identify gene variants, right, which we used to call mutations and use the term variants currently. And that process is where the laboratory, right, identifies and classifies those variants and gives you a report. But that's not the last step. The next steps are, the follow-up interpretation of any pathogenic or likely pathogenic variants that are reported on the text in the context of the inheritance pattern of the gene and its associated condition or conditions, because as we know, some genes have more than one associated condition. And then lastly comes the clinical correlation, right? That's your piece, where the clinician correlates the findings on the genetic test report with the patient's findings. So what's a variant, right? A variant is just a difference in the DNA sequence, which can be large or small, from a change in a single nucleotide to a deletion or duplication of a gene or many genes in a larger genomic region. We know that most variants have no adverse effect, and we also know that disease-causing variants are ones that alter the normal function of the gene or genes in which they occur. And the way in which we determine that is using a framework, right? So since 2015, the American College of Medical Genetics and Genomics and the Association for Molecular Pathology have provided us a framework in the laboratory for variant classification. And it's a systematic approach that uses the evidence for a given variant and classifications based on evidence from population data, computational data, functional data, segregation data, and even other sources. And that framework's really the gold standard we use in the lab for genetic testing and variant classification. And it's important to note, really, though, I like to stress that this is the laboratory piece, right? And variant classification can give a molecular diagnosis, whereas the next steps, those steps that you take, sometimes even in partnership with us at the lab through discussions, is that clinical correlation piece. So here we see an illustration of this 5-tier classification system using the ACMG AMP criteria. And like I said, this is really used by all clinical laboratories in the current era, right, in reporting genetic test results. And so positive results are going to include those where there's a pathogenic or a likely pathogenic variant or variants present, where we expect that those variants are going to have a greater than 90% likelihood of causing disease. Whereas negative results are going to include those that are classified as benign or likely benign. And then we have this tricky middle area that everyone probably has heard about, right? Those variants of uncertain significance or variants of unknown significance, if you will, which is really just everything that's in between well, there's not sufficient evidence to meet criteria for pathogenicity or to be benign. So in that case, the laboratory can't give you a result that's a positive or a negative. And then in some cases with strong clinical information or other data that's provided, a VUS may be upgraded and reclassified as pathogenic or likely pathogenic in the laboratory. That may result in a new result, a new report sent to the clinician. But in fact, we expect that most VUS are expected to be benign as evidence accrues. This concept was new to me in developing gene panels at the laboratory. So I'm curious if it's new to folks on the call here, but it helps me understand why a given gene that may or may not be on a genetic panel, how the genetic test results relate to the evidence basis for a gene disease relationship. So we know that genetic variants in the laboratory setting are going to be reported in the context of this relationship or relationships. And so we define a gene disease relationship as the connection between a gene and the specific disease, and refers to how a genetic variant can lead to a disease or increase the risk of developing it. And that can be a monogenic disease, right, which is a direct association, or a risk association, such as we heard, about APOL1 mediated kidney disease or AMKD. So to use a good example, the PKD1 gene, right, we know has a definitive association with ADPKD. Both clinical and experimental data have strongly and reproducibly demonstrated that PKD is causative of this disease. The PKD1 gene is causative. So in this case, we have a definitive gene disease association, and that allows us, when we detect variants that have sufficient evidence, then to be classified as pathogenic or likely pathogenic. And this just demonstrates that we have to have robust data for a valid gene disease association in order for a variant detected in that gene that's suspected to be disease causing, right, to be reported out in that way. Whereas if you have a very weak or limited gene disease association, the laboratory can't really go higher than a VUS classification. So I think that's useful to understand when we talk about emerging evidence and emerging literature about potential kidney disease related genes and their relationship to belonging or not belonging on a test panel. So next, just want to take you through some pieces of the report just to kind of give some practical ways to analyze a report and understand some of the terminology used and to help you interpret results. So I'm going to use the Renasight report from Natera as our example here. So as you know, the Renasight test currently includes 397 kidney disease genes. And depending on the findings, right, the report will contain 1 to 3 different results sections in descending order of clinical actionability and relevance to the patient's clinical management. So I'll discuss each of these sections in more detail, but on the report, you'll find the results summary first, which indicates if it's a positive or negative result. And then if there are any carrier result findings, those will be listed next on the report. And lastly, variants of uncertain significance. It's important to recognize that some laboratories may report those VUS on all orders. On the Renasight test, given the complexity of dealing with VUS, we've actually, made that optional so that can be ordered on a test by test basis, depending on clinician and perhaps patient preference in your discussion with your patient in terms of how much information you would like to have on a test result and how that may or may not be useful to you. It's giving me trouble switching to the next slide, sorry. Then following the results, you'll find additional information on the test report that's really boilerplate, right? That tells you about the test methodology, how it was performed, any overall test limitations, and then any gene-specific limitations with the technology and variant detection, and then which genes are included on the panel. So that can be useful, recognizing that as time goes on, genetic test panels tend to improve and may have genes added or removed over time as the evidence allows. And so at Natera, we felt that it's important to include on our test results a patient and clinician friendly supplement which a lot of folks miss when they tend to look at the results. So if we scroll all the way down to the end of a Renasight report, the supplement is attached at the end and addresses general questions about the result, any next steps, and how to obtain additional information and support. And our genetic counseling team really vets the resources and references on those supplements so that there's valid sources of information for both patients as well as clinicians to use. And for positive results, that supplement really helps provide detailed information about the condition or conditions related to a positive genetic test result. And patients we find often use that supplement to help them more easily discuss their results with other healthcare providers and other family members who, may benefit from genetic testing. So when you have a test result from Renasight, you'll see the final results summary near the top of the first page. And when no genetic findings are identified that are sufficient to cause disease based on the current evidence, you'll see a green minus sign and text indicating a negative result. And so, as stated in the test interpretation section, not identifying clinically significant variants on genetic testing neither confirms nor rules out a genetic cause for a patient's clinical presentation. So keep in mind that while genetic variants may be reported in the carrier results or the VUS sections that follow on the report, if the overall heading's negative, those additional findings aren't considered diagnostic and they're not expected to provide a genetic or clinical diagnosis, if you will. And so when genetic testing, is positive, and we have results identified that could explain the indication for testing, you'll see the orange plus sign and text indicating a positive result, meaning this result is consistent with a molecular diagnosis of the condition or conditions associated with the variant or variants detected. And just to refer back to the last talk about ordering a broad panel or not, and what might one find? At least in our Renasight data thus far, consistently, we've seen that about 6% of our cases that have a positive result have a second positive finding, and rarely a third positive finding. So those will all be listed on the report. So it's important to keep in mind that a positive result may not always explain or fully explain a patient's clinical features. And when clinical correlation isn't obvious, right? It's possible to have a test result that does not explain what you're seeing in your patient, and that may be confounding. And so we really feel that that's the time when you should contact the laboratory or consult with your genetics colleagues, perhaps at your institution, to help with clinical correlation, variant interpretation, discussions about family testing if appropriate, and so forth. The next column is going to show the kidney-related disease, or the diseases, if you will, if there's more than one gene disease association associated with a pathogenic or likely pathogenic variant in that gene. And so then, referring a little bit further down on the report, you'll see more information that our genetic counseling team has developed in conjunction with our laboratory directors to give you understandable information about the gene and really try to include information about the kidney-related findings that can be expected in the condition associated with the gene. And then the gene in question will be in blue text there, and that's the gene symbol. And then if there is more than one positive result, there will just be sequential information down the report about each of those positive findings. And then next on a positive report, you'll see the inheritance column, and that column refers to the inheritance pattern of the condition, so meaning how that condition runs in families. And you may see inheritance patterns on Renasight that include autosomal dominant, autosomal recessive, conditions that have both dominant and recessive inheritance, or X-linked inheritance. And so, of course, with autosomal dominant inheritance, that requires an individual to have one pathogenic or likely pathogenic variant identified on the test. And with recessive conditions, 2 copies of a variant in the gene to be present. And I'm going to take you through in the next slide some of the more complicated inheritance patterns that some of the terminology may not be quite so familiar. So for X-linked conditions in Renasight, any male or female with a positive X-linked gene result will have a positive result. And so we recognize that females may or may not always have symptoms of an X-linked disorder, but have decided to report those as positive, recognizing that clinical correlation is always important. So we know that X-linked inheritance is associated with disease-causing variants in any gene on the X chromosome, for which males typically have one copy and females typically have two copies of the X. And so here we're seeing a positive result for X-linked Alport syndrome in a male. And so because males lack that second functional copy of genes on the X chromosome, males with one disease-causing variant usually experience a more severe form of a genetic condition than females, but not always. And then I'm going to take you through this table section by section, but when you look over here, this can be confusing sometimes as well for the zygosity. So hemizygous is the term that's used for a male who has a variant in an X-linked gene. And then heterozygous is going to be in that zygosity box for a female with that finding. This slide probably represents one of the number one types of phone calls we take on a daily basis on our team from clinicians who receive, an Alport syndrome positive result. So I'd love to explain some of this to help alleviate any confusion, just in terms of what's static text on the report and then what's variable text. So when we look at this autosomal Alport finding, right? So a patient that has a variant in either the call4A3 or the call4A4 gene, we know that having dominant Alport syndrome is common, right? It is common for folks to have a single pathogenic or likely pathogenic variant in those genes. The static nature of the report in the inheritance section can lead to confusion. So we are indicating here the inheritance of the condition itself rather than our understanding of how that variant acts in that given patient. And that's where the correlation piece really comes in. So, conditions that have autosomal dominant and autosomal recessive inheritance can vary in severity and features depending on the type and number of the disease-causing variants present, which is true for Alport syndrome. Separate from Alport syndrome, in some cases, we're going to have a gene that has an autosomal dominant inheritance pattern for variants in some parts of the gene, and autosomal recessive inheritance for a different distinct condition that may be related to variants either in other parts of the genes or just variants that function differently. So what you can refer back to here on the report is the inheritance for those conditions or genes that have both inheritance patterns of dominant and recessive. You can refer back to the condition list. So we can see here in this example that call4A4 is just linked with Alport syndrome. Whereas if this was an example of a gene that had more than one condition associated with it, that had different inheritance patterns, it would be over here on the conditions list, and we would have a parentheses next to each condition name, AD for autosomal dominant, AR for autosomal recessive, so that you can see more easily which condition is associated with which inheritance pattern. So what we know is that for Alport syndrome, right, an individual with a single disease-causing call4A4 gene variant, for example, would have the autosomal dominant form from a molecular genetic diagnostic perspective. And those folks we'd expect to exhibit milder features than someone with the recessive form where there's two pathogenic or likely pathogenic variants detected, or a combination of pathogenic and a likely pathogenic variant. And just referring back to the great talk here from Dr. Collins, we report out risk allele findings with a complex inheritance pattern for the APOL1 gene. So APOL1 is sort of going to be a bit of a unique case on our test, where the inheritance pattern is defined as complex because it follows a recessive model, but we recognize that additional factors have to occur for someone with the G1 and G2 risk alleles who have at least two copies, right, of those risk alleles to develop disease. And there's all sorts of great questions I've seen here today about how a laboratory should or should not report, and what sorts of additional modifiers may be reported. Those are things that laboratories, including ours, are constantly evaluating and really waiting for the appropriate robust amount of evidence to be present before reporting, in addition to the known established risk alleles for APOL1, before adding on something like a modifier um, that may decrease risk, right, to the reporting. So I think that's always something important to communicate from the laboratory's perspective, is that it's not that we're not aware of a growing body of evidence, it's that a certain amount of evidence needs to be gathered for that robust, gene disease validity, or a genetic modifier, if you will, to start changing the way that we report. Overall, our expectation is that the majority of patients that have a positive APOL1 report are not going to have the protective allele. So more to follow on that, and certainly also more to follow on whether reporting will change over time for individuals that just have one APOL1 risk allele. So just to back that up a second, at least for the current time, Renasight reports will include a positive APOL1 result when there is a G1, G1, a G2, G2, or a G1 and a G2 result detected in a patient. If one risk allele is detected, it will be reported in the carrier section of the report. And again, as you have had displayed beautifully before today, probably, and also today by Dr. Collins, we know the AMKD inheritance pattern is considered complex because additional factors influence the development of disease, and therefore these particular disease-associated variants are referred to as risk alleles in the classification section of the table. So next comes additional information on the report. So when there's a positive result, we're going to have that gene-specific information that tells you about the condition associated with the gene, but then you get to the variant-specific information, the actual meat of the interpretation. And so within each gene listed, that variant column is going to specify the specific genetic alteration. So the nomenclature up here by variant shows you the effect on the gene and the protein, using nomenclature to describe that. We don't necessarily expect anyone to understand that nomenclature or every detail of the interpretation section to be proficient at using renal genetic testing. This is just our way in genetics of describing all of the evidence in a concise way for how that variant came to be classified as pathogenic or likely pathogenic. And you'll find there that there are references for, PubMed references on the report, which are in the blue text here, that lead you to additional literature if you have additional questions about what's been reported for that given variant before. So that's the section where you can do a deep dive to look further about the information that drove the classification of that variant. Here is also where you might see a mention of some information that might help you prognosticate a bit. So for example, for a PKD1 variant, if it's known to be truncating, that will be a bullet point in the interpretation section. And we know that for PKD1 variants that are truncating, they're expected to be associated with a more rapidly progressive form of ADPKD. And so that's some information that can be useful. I think with all of that in mind, though, it's important to acknowledge and understand that when looking at this, that can be quite overwhelming, particularly for someone who's not a regular orderer yet of renal genetic testing. And so this is where it's okay to partner with your colleagues, with the laboratory, and contact the laboratory to discuss any specific questions that you might have about the interpretation section, or for that matter, anything else on the report. And so I did mention a bit about the zygosity column before when we talked about hemizygous in males and heterozygous in females for X-linked genes reported on the testing. So the zygosity section is just going to denote the number of copies of the variant identified. And I'll review the different types of zygosity here beyond what we discussed before. So compound heterozygous is really the term we use when there are two different variants identified in the same copy of a gene. And it's important also to understand that given the NGS technology, right, that's used to perform the testing, given that the short read sequences that are obtained, the phase of two variants reported in a recessive gene on a test report can't usually be determined because usually they're too far apart in the DNA sequence to understand for sure if they are on the same, meaning in cis configuration, or on opposite copies of the gene, meaning in trans configuration. And so if a patient's findings don't correlate specifically to that positive recessive gene finding, I should back up and say, if I have a patient with Gittleman syndrome and they have two Gittleman syndrome variants detected and reported on the test report, it's okay to stop there. Whereas if you have a result where there's two pathogenic variants identified in a condition that your patient clearly does not have, that may be a question of whether those variants are in cis or trans configuration, and that's where additional family testing can be performed to help resolve phase. And so for homozygous variants, that definition, right, is just that there is the same variant identified in two copies in the individual. So just to review, the classification column here is variable as well, right? So this will change and be noted in different sections of the report. So the classification column is going to show where a given variant on a test report falls on that 5-tier scale of effect on gene function from benign to pathogenic. A variant that has a greater than 90% likelihood to disrupt normal gene function is considered pathogenic or likely pathogenic and is reported as positive. Only variants that are classified as VUS, likely pathogenic or pathogenic, will be reported out and visible to you on a RenaCyte result. And as I mentioned, at least at our laboratory, VUS is optional. You can opt in or opt out on a case-by-case basis on that test order form. To take you through carrier results, in the carrier results section, you'll find information about findings for conditions that may have reproductive risk implications. And so carriers, of course, are heterozygous for conditions that are autosomal recessive. Heterozygotes are referred to as carriers because they're at increased risk to pass the condition on to the next generation if the reproductive partner is also a carrier for a variant in the same gene. My notes are reminding me that I said same condition, but I'm like, we get this question a lot. People don't have to be carriers for the exact same variant in a gene as a couple, right, to be at risk of passing it on. It's just the same gene. If one partner has a variant and the second partner has a different variant in that gene, they would have a 25% risk of having an affected child. So patients we would recommend who, I recognize that in the renal genetic testing population, we may have an older overall average age of testing as compared with what I'm used to in the past in carrier screening at Natera. But it's important also to acknowledge that lots of folks have questions about the risk for their children and grandchildren. And so genetic counseling is recommended for folks to discuss questions related to those carrier findings. One additional caveat is that there's always a small chance that a laboratory test cannot detect a second variant in a gene in a patient that presents with classic features of a specific recessive condition. So we would recommend again that you contact the laboratory to discuss results if a patient clearly has a particular disorder, has one pathogenic or likely pathogenic variant detected and reported in the carrier section, but doesn't appear to have a second variant. And so, or if a second variant in that gene is reported in the VUS table, that would be worth a discussion potentially of any next steps. And so then the last section in the report, in terms of variants reported, right, would be the variants of uncertain significance or the VUS. And so here we see an example of the VUS section. And this table, as you can see, follows that same format as for positive and carrier results. And the notable difference is just going to be in the last column where the classification says unknown significance. And the variants shown in this table are going to fall into that gray zone, again, meaning there's not sufficient evidence to say whether this variant contributes to disease. And while it's not uncommon to see VUS, particularly on a broad panel genetic test, it may be helpful to keep in mind that we estimate between 76 and 91% of VUS findings over time as evidence gathers will be downgraded to benign or likely benign. it's really important, I think, to remember that VUS findings are not considered clinically actionable. So patients, if you're reviewing a test report with a patient, can be informed that VUS are to be expected. Every one of us has genetic changes, and every one of us, it is uncommon if you order VUS not to have at least one reported. And so this isn't specifically an abnormal finding. And we cannot confirm a diagnosis, a molecular genetic diagnosis in a patient based on the VUS findings alone. This is a whole discussion topic that we could go on all day about if we'd like, but which I know we do not have time for. But really, there are strategies as a clinician for how to manage VUS and how to get good at looking at a table, triaging those, and understanding what's next. So I would suggest that if a patient has features of a condition that is in the VUS table and is autosomal dominant, that may be worth a call to the laboratory to discuss, hey, can I provide some additional information? Can we do some family testing, things like that to help resolve that VUS perhaps? Whereas if a patient has a single variant reported in an autosomal recessive gene, that VUS is very unlikely, very, very unlikely to be associated with the disease. So I have added a couple slides here before Ronen takes us through some cases, just to say, give you some ideas as to how to correlate a little bit using the test report. So the gene description that I mentioned before can really help you examine whether your patient's findings match this. And I recognize that that can be a challenge because there are going to be rare disorders reported on a broad gene panel. And so it's a matter of saying, gosh, do these features really match my patient or not? If they do not, it may be okay to move on and not spend much time thinking about that VUS. Whereas if they do clearly match, and if a patient has two VUS in a recessive gene with that condition that clearly matches, it may be worth contacting the laboratory. So like I've said here, that inheritance and zygosity are really what you would need to look at to kind of help do that triaging for yourself. But in recapping, I just said these things, right? Does the VUS even match the features? Does the inheritance pattern even match your concern? And then if the answer is yes, it's okay to contact the laboratory and have that next discussion. That's sort of the bread and butter of what myself and my team do day in and day out at the laboratory is answer those types of questions and help determine if we should take some next steps to help resolve a VUS. So next up, Ronen is going to take us through some cases. Thank you, Ronen.
Thank you, Maggie, for the excellent overview of renal genetic test interpretation. I'd like to now share a few illustrative cases of renal-side testing performed on individuals with CKD. And these examples underscore the diagnostic and clinical value of utilizing broad panel in genetic testing in the CKD population. And that kind of just adds to the wonderful cases that we heard before from Dr. Wallace and Dr. Collins. Please note that to protect patient privacy, certain demographic details have been modified here and specific genetic variants information has been covered. Next slide, please. Oh, Maggie, if you can help me out with the slides, please, in advance to the next one. Thank you. So the first case is a female in her mid-30s with a history of preeclampsia in one pregnancy, the only one that she had a few years prior. And she presented with incidentally found proteinuria of 2 grams. Her eGFR was 90 milliliters per minute, and she had mild hypertension. Her kidney biopsy results were showing focal segmental glomerulosclerosis, FSGS. She does have a family history positive for CKD with older brother with FSGS who is now a kidney transplant patient. So the rationale here for genetic testing was twofold. One, she has FSGS, and this is now an indication endorsed by all guidelines, as this was also, I believe, one of the questions on the chat. And the second is that she has positive family history of CKD. Renal site testing found a heterozygous, likely pathogenic variant in the gene called TRPC6, which we know is associated or causative of focal segmental glomerulosclerosis in an autosomal dominant fashion. So what is the importance of diagnosing TRPC6, a rare genetic variant in this patient? First, in terms of prognosis, we establish here a clear molecular diagnosis, but while we cannot draw a precise prognostic prediction in this form of FSGS, we do know that the patient is likely to develop end-stage renal disease at some point. From the treatment perspective, at this time, there is no targeted therapy for TRPC6 mediated FSGS, but there are ongoing efforts and emerging clinical trials to find one. And importantly, in the past, we used to treat FSGS with a one-size-fits-all approach. And today, as Dr. Norouzi also nicely discussed in her talk, we can avoid immunosuppression, which we know is ineffective in monogenic FSGS and is generally or potentially toxic. In terms of the utility for transplant considerations, I want to go back to, for a second, just for the clinical presentation of this family. And if you remember, her brother had FSGS a few years ago, and the kidney donor for her brother was another family member, and genetic test was not done at that time. So just imagine there was 50% chance that the donor also carried TRPC6 variant, and that could be bad outcome, resulting bad outcome, both for the donor and for the recipient, if the donor did have TRPC6 variant. And the fact that the donor was healthy in terms of kidney function at the time of donation doesn't exclude that they carried the variant, simply because in autosomal dominant disorders, we know that there's some variable expressivity. And so the utility for the family is to inform family members, and when there will be a transplant consideration for this particular patient, we should be very careful and test potential donors. Next slide, please. So this next case is a case of CKD stage 4 in a man with hypertension and non-steroidal anti-inflammatory drug used in the past. And this CKD4 is actually attributed to these etiologies. He does have history of gout and a sibling with renal cysts, but with normal kidney function with this, for the sibling. The father did have renal transplant in his 40s, and there's another parental side family member with a history of end-stage kidney disease. So what is the rationale for genetic testing here? We want to clarify the etiology of CKD. So this is essentially CKD of unknown etiology. And as Dr. Norouzi and others mentioned before in earlier talks today, hypertensive nephropathy often is a diagnosis of exclusion. We don't really know the etiology in these cases of CKD. NSAIDs as well. So it's a presumed diagnosis. So we want to clarify it. This is one indication. The other one is the positive family history of kidney disease. But note that the positive family history also in this particular family is variable. So the sibling, for example, has normal kidney function. And remember, often we do not have the family history, or we don't know about other family members with kidney disease, or the presentation is so variable that it is just overlooked. So it is an indication and a strong one, but please remember that if you do not have positive family history, it does not exclude a genetic cause. So we need to keep our mind open. Next slide, please. We did run a renal site test for this patient and found a UMOD mutation, a heterozygous pathogenic variant in the gene UMOD, which is a known cause of autosomal dominant tubulointerstitial kidney disease. In fact, it's one of the most common causes of AD-TKD. Next slide, please. This slide is from the KDIGO. I want you to please just focus on the red bracket there in the table that points to the clinical features of UMOD-mediated AD-TKD. If you try to kind of just hold for a second and imagine your kind of the spectrum of patients that you all see in your nephrology clinics, you would realize, I believe, that many patients fit that spectrum of signs and symptoms. So one of them is hyperuricemia. Many of our advanced CKD patients do have high uric acid levels. Early gout, occasional renal cysts, also pretty common finding in our general CKD population. And look at the range of end-stage kidney disease development, 25 to 70. These, together with intrafamilial variability in UMOD-associated AD-TKD, makes it clear that sometimes the family history is overlooked. And with this general presentation of CKD that is usually attributed to other reasons like hypertension, we need to think genetics here and make sure that we understand the etiology of the CKD in our patients. Next slide, please. So the clinical utility here is one from the prognostic standpoint. We reclassify the etiology here from hypertension or NSAID-induced to AD-TKD UMOD. And that also explains the history of gout. In terms of treatment, we can discuss or identify risk factors for progression to end-stage kidney disease. And we also ask ourselves, do we need a kidney biopsy here? We know that kidney biopsy is not benign in all cases. It bears some risk. And also in UMOD, the histologic findings are most likely to be non-specific. So we may want to skip a biopsy in this case. We do not have a targeted therapy for UMOD at this time, but there are ongoing clinical trials. In terms of transplant or utility for the family, so we know that essentially a kidney transplant for an unaffected donor is curative. And when we do select the donor, we want to make sure that they don't carry the same variant if it's a family member. Next slide. The next case, this is not a glomerular disease and maybe out of the context for today, but I did want to kind of include it here to show you that it's not only the classic findings or the most common findings that we always find and we commonly kind of discuss in these kind of meetings, like, FSGS or APOL1 or Alport. This is a case of a female in her 50s with a history of seronegative rheumatoid arthritis that was treated with multiple lines of therapy for rheumatoid arthritis for over a decade. Nothing really helped. She also has dry eyes that was diagnosed, and she was diagnosed with angioid streaks. And she referred to nephrology actually for hyperphosphatemia. Her kidney function and her blood pressure is totally normal. And she has negative family history for CKD or any other related disorders. So the rationale here for genetic testing was actually just to look for the etiology of her hyperphosphatemia. Next slide. Renal found a homozygous, likely pathogenic variant in the gene GALAN3, which is a known cause of hyperphosphatemic familial tumoral calcinosis in an autosomal recessive fashion. Next slide. The utility here in terms of prognostic, one, I think very importantly, it completely reclassified her disease, which wasn't a CKD diagnosis before. it was rheumatoid arthritis. But now we know that most of these findings, joint, angioid streaks, and other findings like abnormal mammography with calcifications, were all secondary to this GalNT3 mutation. That also reflects on the treatment, right? This reclassification resulted in us avoiding all the immune modulating agents that she was receiving before for rheumatoid arthritis, as I said, for more than a decade with very limited benefit. The utility for family is just to screen other family members clinically to see if there's other people with hyperphosphatemia who could benefit from that knowledge, and we can avoid this diagnostic ordeal or misclassification of disease, like with our patient, and treat or target the hyperphosphatemia levels. And the utility for transplant here is probably low because her kidney function is normal and she's not expected to develop end-stage kidney disease. Next slide. And this is a case of a patient with hypertension. Obviously, we see all of us in renal clinics, many patients with hypertension. Hypertension is just often secondary to CKD, right? And this is a male with in his 60s of African American ethnicity with a history of hypertension and hyperkalemia. And he has a mild CKD, CKD2, but a strong positive family history for hypertension. Mother, sister, and sister's son. So hypertension also in young age. So the rationale here for genetic testing was to find the etiology for hypertension in light of the positive family history. Next slide, please. In this case, we found a heterozygous, likely pathogenic variant in a gene called KLHL3, which is a known cause of pseudohypoaldosteronism type 2D, or AKA Gordon syndrome. We also found a single risk variant in APOL1 gene. Next slide, please. So the importance here in finding that cause of his hypertension was one, reclassification again from hypertensive nephropathy or essential hypertension to actually to Gordon syndrome. And that leads us to the clinical utility, because knowing the exact gene that is involved or the etiology for both the hypertension and probably of the CKD is that we can now target with clothalidone, which targets the NCC channel, which is the exact site of pathophysiology of Gordon syndrome. Utility for family is to inform all these affected family members who also have hypertension and hyperkalemia, and so to guide their therapy with clothalidone as well. And utility for transplant, for this case specifically, probably not high, as he has a pretty mild CKD at this stage and at this age. Next slide, please. This is a case of CKD in a patient of African ancestry, and I think it was discussed extensively by Dr. Collins before. In this case, a male in his late 20s who presented with CKD stage 3 and hypertension, and the provider was suspicious about APOL1 given patient's ancestry and disease progression at a younger age, and offered the genetic testing. Next slide, please. And we found in this case two positive variants. One in APOL1 as suspected, so in G1, G2 alleles. And the other one was COL4A3 related Alport syndrome gene mutation, which was pathogenic as well. Next slide, please. So the clinical utility here, we found a dual diagnosis actually of APOL1 and autosomal dominant form of Alport that could explain both, which could explain CKD at a young age. So this patient, we know now, is at increased risk of end-stage kidney disease. What's the utility of knowing about these two genes? We want to look for extrarenal features. So the clinician suspected APOL1, but now he knows that we need to also look for vision issues or sensory neural hearing loss to screen for these problems. In terms of treatment, we direct treatment with ACE inhibitors. Now, SGLT2 inhibitors probably are also indicated with this for these patients. We know that we avoid treatment with steroids. Had this patient undergone a kidney biopsy and we see an FSGS, as was discussed before. And since he has two risk allele for APOL1, we also want to consider him for clinical trials for APOL1 or emerging trials in Alport syndrome. For the family, again, the family members are at increased risk both for APOL1 mediated kidney disease and for Alport, which is inherited separately. So genetic counseling can define this risk for family members and help with the testing and also guide transplant questions in terms of donor selection and so forth. Next slide. Yeah, I'll hand it back to you, Maggie, for some wrap up. Thank you.
Ms. Westemeyer, you are
You're
muted.
muted. Yeah. You're still muted, Maggie, I believe.
Oops, that was the trouble. So sorry. Yes, thank you, Ronen, for sharing those great cases. And we just like to wrap up by putting the key pieces together here. So just as a review, we know that variant interpretation at the laboratory follows a clear methodical process and is based on our current knowledge at the time of reporting. But we know that that knowledge is continually evolving, and genetics will continue to evolve with improved reporting and additional evidence as it accrues. Variants may, have changing classification and so forth. And so because of this, we encourage clinicians to interact with the laboratory by providing clinical information on the test order form when you can, or by reaching out to our clinical team or your laboratory's clinical team whom you work with to share that information, even following testing. While VUS can be perceived as a barrier to testing, we expect that the vast majority will be eventually downgraded when evidence mounts to show they're benign. But if you choose to further investigate a genetic test result, you're really generally at any laboratory welcome to consider contacting that laboratory, having a discussion with a medical team member at the laboratory, or utilizing your genetics colleagues at your centers, such as genetic counselors and medical geneticists, to understand really the best next steps for the patient. Again, looking at some of the comments and questions, right? Some of those next step types of questions may be, when is it appropriate to or not appropriate to move on to an additional test, such as a whole exome sequencing test or a whole genome sequencing test, right? So the Renasight test is performed on an exome backbone, but is only reporting out and only looking at the data, right, on those 397 genes that we're testing and reporting on. So there are additional tests, but there's benefits, risks, and limitations to those, and those are important discussions to have. And in general, and that's not something, just as follow up to a question, it's not something that our laboratory is currently offering, but in particular cases may be beneficial to particular patients. So any of those questions, those types of questions I see in the chat, like, gosh, my patient is a carrier for this disease, and I think they're affected with that disease. It's very difficult to answer that without knowing someone's individual history and kind of understanding what's going on and whether there should be any further investigation of a second variant not detected with the NGS methodology, recognizing that NGS methodology is very good and going to detect the large majority of causative variants in a given gene. So those really are unique individual case-based questions. And that's where my team is staffed to help answer those on the daily with clinicians who want to take, just want to understand the results better and know if they should be doing more, if they should worry about a variant or not. That's really what we're here for. And the same, I would imagine, goes at any other laboratory that offers renal genetic testing. And just as a reminder for how to contact our laboratory if there are questions, we staff a call line Monday through Friday for providers to email or call in. And the phone number and the email for my team are located here. The call line will take you to the customer service who will transfer you to the genetic counselor on call. And then patients are welcome to go online. So they're not welcome to email us. Thank you very much. But they're welcome to go online to schedule at naterasession.com a session with the genetic counselor at Natera to review test results or answer pre-test questions. Patients are also welcome to call that 650 number here to schedule as well if they can't go online. And so just to summarize why genetic testing, we realize that these rapid advances in NGS sequencing have expanded our understanding of the genetics of kidney disease. It's a really cool time to be working in genetics with kidney disease. Major nephrology societies have emphasized the critical role of genetic testing in diagnosing and managing kidney disease. And we hear back from the patients how beneficial and useful that information is, even in cases where it doesn't change treatment, just understanding their diagnosis and how important that is to them is important to, I feel, acknowledge as well. So we also note that broad panel testing is continuing to be endorsed, such as in the National Kidney Foundation's recent consensus statement. Hope that you remember that an accurate laboratory genetic diagnosis entails variant interpretation, followed by that genotype-phenotype correlation, and that referral to genetics is always appropriate if you need to. And that we believe now is the time to improve diagnosis, enable more personalized treatment with genetic testing for your patients. And we probably have a couple minutes for questions, but we can also follow up with folks gladly by phone or email after today. Thank you.
Fantastic. Thank you so much, Ms. Westemeyer and Dr. Schneider. That was excellent overview of the reports that we often receive and how to go about interpreting them and taking it the next steps around that. I think a lot of the confusion questions are often, as you have emphasized and discussed, is around the variant of unknown significance and so on. There was one question here, I think, and you a little bit alluded to. So your panel is on the backbone of a whole exome sequencing. So is it possible then to go back and ask specific questions, like, for example, specifically evaluating certain mutations, be it like, let's hear an example by Dr. Carriazo, APOL1 gene, let's say there is a pathogenic variant. Can you go back and look at the N264K variant as well or not?
It's a great question. Not outside of a research setting.
Okay.
Yes.
Okay. So, and then how
so
about
whether that decision will be in future to add that to the report, we would advertise that and communicate that to the field if we were going to make that update to the reporting strategy.
Okay. And in the same line, also, let's say we obtain the panel. Your panel has how many genes currently?
Currently 397.
397. So today I test my patient, 397 genes. Let's say my patient has FSGS. 397 genes is negative. We know that over the next 5 years, in the next 5 years, science will educate us maybe about 5 new genes or 5 new mutations within the tested genes, or 5 new genes that were not within your panel. Do I need to retest the patient, or can I have just that same test reanalyzed and reported?
It's such a great question. And I recognize that I represent Natera and that there are certain answers that are going to relate to our lab processes and ordering and reanalysis, and that those are going to vary also by laboratory, if that makes sense.
Yes.
So those questions are probably best answered on an individual basis to help. Like, these, I feel, are the best discussions to have with a clinical team to understand how much maybe was captured, right? And what was, it's important to also then understand from the laboratory that you're working with, will they when a variant is upgraded to pathogenic, release new results and send those to you. In Natera's case, the answer is currently yes. But as a genetics community, this is a wonderful question as we accrue all of this data and things. How are laboratories resourced? If you have tens of thousands of cases in past to update and send those reports, those are challenges that all laboratories face as we move forward with testing. So this is why I feel that the best questions are the best answers to those types of questions really come through one-on-one discussions on individual cases and recontacting the laboratory in those cases where they were negative in past and you're curious if there's been change in classification. We can help provide that information by communicating with you by phone or email and interfacing with the laboratory in our case. Whether some laboratories will charge for reanalysis and their billing strategies, right? Or whether in future Natera would offer a reflex to an exome-based test, which is not something we currently offer, are all excellent questions. And again, are probably laboratory dependent. So all valid questions. It's a complex landscape when it comes to those sorts of questions, but I want to answer that a little bit broadly today, given those reasons.
Understood. One more question is, when you do whole exome sequencing, could the patient get the entire sequence?
A patient can, and this is again where we have to be careful between a research request from a clinician and a patient's right to data. And so patients do have the right to contact the laboratory to request their data files.
Okay. And so you would give them a hard disk, or how would it work?
Yes,
A thumb
and this is
drive?
almost comical that I do not recall the exact method in which we provide that to the patient. But yes, indeed, the patient is provided with those files. And as I recall in past, I used to know about this a little better. I'm sorry that I know today.
No. Okay,
But yes,
that's
but
just
whether it's
specific.
a hard drive or whatever it
Yeah,
happens to be,
got
yes,
it.
that is
Okay,
provided.
excellent.
Yes, indeed.
Thank you so much. Good, wonderful. We are about time. This was fantastic. A great session all day. Fantastic talks. Thank you again to all the speakers. Thank you, Dr. Schneider. Thank you, Ms. Westemeyer, and all the prior speakers, and all the participants who stood all day, night, in the morning. I think it was like one of our speakers here. Is he still here? It was 4 a.m. He was tweeting that he's still wide awake and enjoying it. So thank you all. Yes,
Thank
there
you.
you go, Yudhishthira. Great seeing you. Have a good night and good rest of your day, everyone. Bye.